Good afternoon, everyone, and welcome to our live event where we're going to be talking about a really important topic, and that is we're going to be talking about an interesting form of a blood cancer that no longer responds to traditional types of treatment. And I know that you've just recently seen some pretty big words, and we're really going to take a minute and break all of that down. So I want you to get a piece of paper and a pencil handy. We're going to give you a lot of information. We're going to be putting information in the chat function, but we're just going to really walk through, I think, this really important topic. My name is Linda Bohannon, and I am the CEO of the Cancer Support Community. And I'm so thrilled to be here today with Dr. Kami Maddocks. You can see her already on the screen. So Dr. Maddocks, it's good to see you. Let me just tell people a little about you. You are a hematologist, which means that you're a blood doctor. You specialize in blood disorders, and you specialize in treating people with blood cancers, including B-cell cancers like non-Hodgkin's lymphoma, Hodgkin's lymphoma, chronic leukocytic leukemia, also known as CLL. And you also excitingly conduct research on new therapies, which makes you really the perfect guest for our conversation today. And you are located at the Ohio State University in Columbus, Ohio. So you're a fellow Midwesterner. I'm actually sitting in Indianapolis, Indiana today. And so we're not too far apart. So thank you so much for joining us today for this important conversation.
Thank you so much for having me. I'm excited to join you.
And for those of you who aren't necessarily familiar with the Cancer Support Community, I know a number of you have found us either through our Facebook page or our YouTube channel. But just to remind you, we are an international organization. We are known as the Cancer Support Community and also Gilda's Clubs. So if you're in a city where there's a Gilda's Club, they are also a part of the Cancer Support Community Network. And we do social and emotional support for people with cancer and their families, as well as research and public policy. So we'd love for you to get involved with our organization in any way that you're interested. And we do have a telephone helpline. That number is 888-793-9355. And we would love for you to have that on speed dial and tell your friends who may need our services. And that number is answered 7 days a week by licensed mental health professionals. And we're here to help you with anything that you need really on your cancer journey that we can provide for you. So that's a little bit about us, a little bit about Dr. Maddocks, and let's get right to it. We're going to break this whole thing down. You know, in the introduction, we said when new options for diffuse large B-cell lymphoma that doesn't respond to treatment. So let's take people way back to the beginning and start with, what is lymphoma to begin with?
So lymphoma is what we call a blood cancer or a hematologic malignancy. Our body has white blood cells in it, and those white blood cells make up our immune system, and there's a bunch of different kinds. Lymphocytes are one of those type of white blood cells that help us fight different infections. So lymphoma is when there's a cancer of those lymphocytes, or those lymphocytes turn bad and grow out of control.
I'm on mute. There are different types of lymphoma. So walk us through, and even in your bio, we mentioned Hodgkin's lymphoma, non-Hodgkin's lymphoma. So how many different types are there? What makes them different? And why is it important that people understand the type of lymphoma that they have?
Yeah, so there's actually between 80 and 100 different subtypes of lymphoma that you can keep breaking down. But we think of it in general, so there's first two large categories. There's Hodgkin's lymphoma, which has 5 different subtypes, and then non-Hodgkin's lymphomas, which are much more common. And actually, non-Hodgkin's lymphoma are the 7th most common type of cancer in both men and women. There are several different subtypes of non-Hodgkin's lymphomas. The first way we break them down is if they're B-cell lymphomas or T-cell lymphomas. So there's different types of lymphocytes, and you can have lymphoma of those different types of lymphocytes. About 85% are going to be of the B-cell variety. And that's diffuse large B-cell, you mentioned, is one of those subtypes. Between the B-cell lymphomas and the T-cell lymphomas, the other way we break them down is by aggressive lymphomas or indolent lymphomas. So aggressive lymphomas tend to come on quickly. They need to be treated, soon after they're diagnosed. In general, they're curable. We don't cure everybody, but they're potentially curable with treatment and potentially, curable at relapse. Indolent lymphomas are a lot more like a chronic disease. There's something that usually develops a little more slowly. Sometimes it causes symptoms, but sometimes they're found incidentally when other tests are being done. They are treatable, but not in general considered curable. So you can give them treatment when somebody needs treatment. They often respond to treatment and maybe get into a remission. But we know that if somebody lives long enough after their diagnosis, that's something that can kind of continually come back. You treat it again, it goes, get it back under control. And it's kind of this pattern of relapses that you again then get under control.
Mm-hmm.
Diffuse large B-cell lymphoma is the most common type of aggressive lymphoma, but there are other aggressive types such as Burkitt's and double hit lymphomas, primary mediastinal lymphomas. Indolent lymphomas, follicular lymphoma is the most common type of B-cell indolent lymphoma, but again, there are several others.
Mm-hmm. And I'm just fascinated by this, right? Because I've been an oncology nurse for close to 40 years now, and there's just been such an explosion in learning more about the types of lymphoma and how to treat them that I'm personally very grateful for those of you who have really led this work, and grateful for the patients that you're serving today, because they do have so much of a different experience than the patients did back when I started in the 1980s. So with all of this information, and I'll just pause to say that we are going to put a link in the comments to our information on our website, because we do have information that really sort of walks people through the names of the types of lymphoma that you've mentioned. But with all of this information, talk to us about why it's so important that patients see a specialist to get that right diagnosis, and how are patients with lymphoma diagnosed to begin with?
Yeah, that's a great question. And as I mentioned, there are so many different subtypes of lymphoma. And while some of them maybe are treated in a similar way, they're each treated individually based on their subtype. So it's so important in lymphoma to make sure you know what subtype you're dealing with, so that you can direct the right treatment, both, the first time somebody needs treatment and then if the lymphoma comes back. So lymphoma is diagnosed by a biopsy. Typically that biopsy is done of a lymph node. Ideally, you want to make sure you get enough of that lymph node so the pathologist can do a bunch of different tests on it. So usually we either, if there's a lymph node that's easy to get at, it's often taken out, or a chunk of it is taken out. Occasionally, people will be diagnosed because they will have a bone marrow biopsy. That's where the blood cells are made. So lymphoma cells can be in the bone marrow also. And very occasionally, some of these lymphomas actually can have cells in the blood, and some tests can be diagnosed on those cells too. But most often, it's going to be a biopsy of a lymph node. Initially, what happens is that lymph node, the pathologist, so the specialist in diagnosing, tissue, looking at tissue and making a diagnosis, looks at it and just, looks at how the cells are interacting, and that tells them some things about the lymphoma. Then they put special stains on the slides from the biopsy. So they put stains on the tissue that helps us to know what proteins that lymphoma is expressing, and that can further categorize what type it is. Then they also do something called flow cytometry, which also looks at what proteins are being expressed on the cells. And lastly, we can do some molecular studies. So there's certain chromosomal abnormalities that the lymphoma has, not necessarily the person, but that is characterized from the lymphoma, that you can test for to further define it. And even certain mutations that can be looked at that may even, come more into play at relapse. and those mutations might help you decide treatment. So there's so many different things that we look at, and it's important that all those are evaluated to get the right diagnosis so you can direct the right treatment.
So how do people present to you, right? Is it that they have a lymph node? Is it on a routine blood test? How do they initially present typically?
So there are different ways that people can present with lymphoma. Some of it depends on the type of lymphoma. So a more aggressive lymphoma, sometimes people will note a mass in the areas that we have our lymph nodes. So they might notice something in their neck, in their axillary armpit area, in the inguinal or groin area. Aggressive lymphomas sometimes will cause symptoms that we call B symptoms. So like daily fevers without having an infection, night sweats, which are like drench the bed, have to change your clothes because you're so wet, occur every night. And weight loss. So despite, eating and doing their normal things, they continue to lose weight for no reason. Some people can present with pain if the lymph nodes are, lymph nodes or lymphoma, really because it's a blood cancer, it can go anywhere. So pain from involvement of any organs or lymph nodes. And then lastly, sometimes people do present with blood change abnormalities like low blood cell counts or high blood cell counts, so high or low white cell counts, or they can have low platelets or be anemic, by meaning having a low red cell count or low hemoglobin.
And so presentation, diagnosis, let's talk about treatment for a second for these people that are newly diagnosed. And then we're going to wrap back around to those questions again and talk about if they recur, how do you follow that whole process again? So typically when people are newly diagnosed, how do you treat them?
So in general, treatment for lymphoma is something, because it's a blood cancer, it's not something that you can just cut out. Because that system runs throughout the whole body. And even if it's in one spot, you always worry, is there some little cell that got loose? So in general, this is not something that we do surgery on outside of making the diagnosis. So most often it's treated with what's called systemic therapy. So systemic therapy would be therapy that's going to get everywhere. Most aggressive lymphomas are going to be treated with a combination of chemotherapy and immunotherapy when they're first diagnosed. And then as far as radiation goes, it's not used alone in the treatment of lymphoma. In general, it has some role in like indolent lymphomas that are just in one area. It's occasionally used after chemotherapy depending on stage and different factors associated with the lymphoma. So most people that have an aggressive lymphoma like diffuse large B-cell lymphoma are going to be treated with chemotherapy, which goes everywhere, is meant to target really cells as they divide. Cancer cells, lymphoma cells divide at a more rapid pace. So it's really aimed at stopping that growth. But the side effects, of course, come from, some of the good cells that the chemo also kills too. Immunotherapy is therapy that's more targeted at the body's immune system. So to directly targeted at either killing those lymphoma cells and not other cells, or activating the body's immune system to kill those lymphoma cells. There are some targeted therapies. So there are oral targeted therapies, often used either in indolent lymphomas when they're first diagnosed, or in aggressive lymphomas relapse. Other immune therapies and pills that we call immunomodulator therapies. And then, well, I think you said we'll get to this, but there's also a role for stem cell transplant. So but that'll be in relapse, so we can talk about that. Do you want me to talk about that now or when we get into relapse?
No, I think that's great. So we'll go ahead and talk about that, because people are treated, and then what happens? Both ways.
So people are treated, Yeah, so when you look at an aggressive lymphoma like diffuse large B-cell lymphoma, somewhere between 60 to 70% are cured with their initial chemoimmunotherapy. For those patients who so essentially three things can happen. One is they can get a response and there can be no detectable lymphoma, and then it can come back in the future, or what we call relapse. Some people, it does that in a few years. For some people, they might get a short time where it's in a remission or not detectable, and then it comes back within a few months. Some people, you treat them and some of it goes away, but it doesn't all go away, which in an indolent lymphoma is sometimes okay. You can sometimes watch them then as long as they're feeling better, but in an aggressive lymphoma, if it doesn't all go away, then it's just going to progress, because again, that's an aggressive process. And then lastly, there's a small percentage of patients who don't respond to their first treatment, and actually their lymphoma grows through that treatment. So whether somebody with aggressive lymphoma, doesn't respond to the treatment, doesn't go all the way into a remission, or it doesn't become undetectable, or it relapses, then they need more treatment. So we base that treatment on the patient's, how healthy they are, somewhat their age, but more just in general what their other medical problems are, what we call comorbidities. So if patients are candidates for what we call aggressive therapy, so it's still potentially curable at this point, but they need a new type of chemotherapy, and then we talk about doing a stem cell transplant. So a stem cell transplant is a bone marrow transplant, only now we get the cells from the blood. The stem cells are collected from the blood, and there's two different types. One is called an autologous bone marrow transplant, which just means a transplant from yourself. You give yourself your own cells. And then there's an allogeneic stem cell transplant, which is a bone marrow transplant from somebody else or from a donor. Most of the time in lymphoma, we're going to do one from yourself or an autologous one first. And maybe down the line consider one from somebody else if we can't get it to respond to a transplant or other therapies. For patients who don't get into a remission still with a second therapy, or who maybe get a transplant and relapse after it, or for patients who maybe get a couple therapies but aren't, their body's not able to tolerate a stem cell transplant, there is a new therapy that's been around for about 3 years called chimeric antigen receptor T cells, or CAR T cells, which maybe some people have heard of. And this is considered an immune therapy, but what they do is, instead of collecting your stem cells for the transplant, they collect your T cells, so another one of your immune system cells, and those cells are sent off and they're re-engineered or tweaked to be able, and then they're sent back and you're given those back. And the idea is that they're supposed to then recognize the lymphoma as, bad, your body's not recognizing it as bad, but they do. And then they attack the immune system and activate your body to attack the lymphoma. The other thing that can be done is, if patients aren't able to get those treatments, is now we have different chemotherapies, immune therapies, and targeted therapies also approved at relapse. We've seen, since the approval of CAR T, we've also seen 3 other different drugs or regimens approved in relapse or refractory diffuse large B-cell lymphoma. So it's, in general, it's an exciting time for lymphoma patients, because in the last few years, we've seen, so many options that they didn't have before.
Yeah, so the good news and what I'm hearing are these options. So if I'm a patient, right? So number one, maybe we should just make sure that patients understand the difference between relapse and refractory lymphoma, in case they hear those terms.
Yes. So relapse means that it went away or it wasn't detectable and it came back, whereas refractory means it never went away. In general, they're approached the same way, like your approach to treating them is similar. It doesn't necessarily change, but we do worry about in a patient who's refractory to one chemo, meaning that chemo doesn't work, at least in a patient who relapsed, it works for a while. So it's what we call responsive to the treatment, meaning it did affect it, it just outsmarted it in the end. Whereas with refractory, we worry that it's going to be harder to get them to respond to chemo, even if we do a different chemo, because for some, there's something about their lymphoma that seems to be, smarter than the chemo to begin with.
Mm-hmm. So we talked in the beginning that a person who's newly diagnosed goes through a battery of tests to be diagnosed. So after somebody has had their treatment, I know from experience and from talking to patients that you watch those people pretty closely. So what is that process like of just keeping an eye on them? When do you retest them? How do you retest them? And then how do you make that next decision? What goes into that?
That's a great question. So in general, we use a mix of different kinds of tests when somebody's first diagnosed to understand where all the lymphoma's at. So there's CT scans, CAT scans. They help us measure size of lymph nodes or areas that are involved. PET scans, so they use a glucose type solution, and the more active something is, the more of that solution it takes up. So they measure activity. And so they tell us really where in the body there's areas that has more activity and that are suspicious for being involved with the lymphoma. The more aggressive a lymphoma is, the more beneficial the PET scan is. So in something like diffuse large B-cell lymphoma, it's standard to use a PET scan. Some of the indolent lymphomas, they may not be as accurate, and the CT scans might give you more information. And then also, if there's concern that there's cells in the bone marrow, we ought to check that so that we can know at the end if it was there, if it's gone. Typically, patients will get a scan in the middle of their treatment to see how things are going. And then at the end of their treatment, which diffuse large B-cell lymphoma, you get 6 cycles of chemoimmunotherapy, which takes about 4.5 months to get through that treatment. And then somewhere between 4 to 8 weeks after you finish that treatment, you get another PET scan to make sure that everything is gone. Once you've seen that everything is gone by the PET scan, then I typically see patients every 3 months for the first 2 years after treatment. And they just get an exam by me, they get their labs checked, and then we ask them questions to make sure that we don't hear anything that's concerning to us about symptoms. They used to recommend routine imaging like CT scans at those visits, but there's been several studies that have shown that getting CT scans in fact does not, that patients either have symptoms or the doctor feels something or the labs are off, and that by doing all those extra scans, you don't catch it necessarily earlier and it doesn't change the outcomes. But by getting all those additional scans, what you can do is, cause more worry for the patient. You can find things that may or may not be something, and then you end up getting more tests and you're exposing them, to the small dose of radiation from those scans. So now it's just all based on patient symptoms, lab works, and exam. Mm-hmm. The chance of it coming back if it goes away is highest within those first 2 years. So if somebody's going to have a relapse, 90% of the time it occurs within those 2 years after finishing treatment. Only 10% of the relapses occur after that 2-year time frame. So after 2 years, we continue to follow patients, but we extend it out to 4-month visits and then 6-month visits and then yearly visits. Typically, an aggressive lymphoma patient will follow for 5 years after treatment. And then after 5 years is up, we say they should be seen yearly by us or a PCP just to have a yearly exam and CBC or blood count check. Indolent lymphomas, we often follow for a lifetime just because, as I mentioned, that's something that's more like a chronic disease. Now, say you get that scan after therapy and there's still stuff like lighting up or bright on the scan, then you have to biopsy it because PET scans are not specific, meaning that while they're concerning for cancer, they can anything like infection or inflammation can also light up on a PET scan. So you always want to biopsy after treatment if something looks suspicious to make sure that it's indeed lymphoma and not something else, because you don't want to give more treatment if you're not dealing with the same thing. And then if there is still lymphoma, then you move on to the next treatment, and that would be, a refractory situation.
So when you do that biopsy the second time around, and I'm really glad that you touched on a couple things, either before and now. The idea that you can't just take out the lymph node, right, in this situation, I think is really important for people to understand. Then when you think about doing the biopsy, in the refractory setting or the relapse setting, do you send it back for that same battery of tests, right, to look at the markers and the mutations and all of that? Or is it a different panel that you do?
So typically the important thing at that time is just making sure that it's in the same lymphoma. So you don't necessarily have to, if you noted chromosome abnormalities, you don't necessarily have to send them again if the other features are the same. You just want to make sure that, yes, this is the same, if you have aggressive diffuse large B-cell lymphoma, that yes, you're dealing with that. It doesn't, if you had those markers to begin with, they're going to be there, and that doesn't change anything. The few things that can happen besides, besides it being something else and besides it being that type of lymphoma. So very occasionally, indolent lymphomas will become aggressive lymphomas. So follicular lymphoma can do what we call transform into a diffuse large B-cell lymphoma. So there's sometimes people will have an indolent lymphoma that they don't know it, and they present with transformation. So they present with essentially diffuse large B-cell lymphoma. But what happens is once they finish treatment or once they have a relapse, you'll actually find that they relapse with indolent lymphoma, like a follicular lymphoma, which is going to be treated different. So that's important in that situation. The other thing that can help, and I see this changing probably in the future, but as I mentioned, there's like sequencing and different genetic abnormalities or different mutations that can be associated with lymphoma. And those mutations right now don't necessarily change what we do for the first treatment, but maybe if somebody has a lot of relapses, you can use those mutations to identify a therapy that works, and more we're studying targeted therapies in lymphoma. So now that might be something that helps you find a clinical trial at relapse, or if there's a medication that you can use to target that. But that's something that might be beneficial and tested at relapse. Again, not now does it change the first treatment you get, but that's something that might happen in the future.
Okay, so stay sort of with that theme. And if you have somebody, because I know we have a number of people that are listening either now or will listen to the replay who are relapsed or refractory, or their families are relapsed and refractory. So they're looking for solutions, for those people. So what are some of the thoughts or patient characteristics that you consider when you're thinking about how to treat this person in front of you, which may not be the same person, or may not be the same reason that you treat the person that comes in an hour? So talk us through, how do you make treatment decisions in partnership with patients?
So when we're talking about just lymphoma and treatment options in general, depending on the type, there are different treatment options. Like I said, aggressive lymphomas are, for the most part, treated with the same treatment for the first treatment, but at relapse, there might be different options. Indolent lymphoma, you might have a few different options. And you have to really look at the patient disease and characteristics. So the patient, how old is the patient? What other medical problems does the patient have? Do they have heart disease? Do they have lung disease? Are there different things that are gonna, that they're gonna have more toxicity or more problems tolerating a chemotherapy? What is the patient's preference? So when a lymphoma relapses or is refractory, sometimes there's, different options that you have, and you have to really get what does the patient want out of this? Are they concerned about certain side effects? Are they concerned about, how often they have to come to the clinic to get treatment versus being able to maybe get less frequent treatments or being able to take a pill at home if that is an option. How did they tolerate their first therapy? Some people don't have a lot of side effects from their first treatment, and then there's people who actually have a lot of different side effects from their first treatment. And so you have to think about all those things when you're deciding what you give them after the first treatment. Some people have side effects that remain from their first treatment. So like something called peripheral neuropathy or damage to the nerves. That's a common thing with some of the different chemos. And if somebody still has that from a treatment they received, you may think about, not giving them another drug that's going to make that worse if you have other options.
So you had mentioned a few treatments. You mentioned the CAR T is an example of a new treatment. And you mentioned that there have been, 3 or so others that have been approved recently. So, you don't have to talk about those specifically, but as a physician, how do you make your decision around which of those that you might offer a patient when? And we are going to go to clinical trials in just a second after we get through the establishment.
So that's a great question. So, typically part of the CAR T cells, so right now they're only given, they do have side effects, so they can really, your immune system is activated and they cause side effects called cytokine release, or they can cause some neurotoxicity, which is, really a lot of that comes from your immune system being very activated and excited. So those are only given at places that also do transplants. So they have to be given at specialized centers. Patients have to be candidates, so they have to be able to tolerate the side effects of those. They have to have access to a place that gives them. And really because it's a process where they collect those cells and it takes about 3 weeks for them to be returned to the center, and then they get them. Sometimes people's lymphoma is progressing at a pace that can't wait, and so you have to, give them something in between, or it can be logistically difficult. The other treatments are all a form of targeted therapy. So there is an antibody drug conjugate called polatuzumab, approved in combination with a chemotherapy. There's targeted therapies, another immunotherapy called tafasitamab, approved with an oral immune therapy called lenalidomide, and then an oral pill called selinexor. Those last two were just approved this past summer. So when you're looking at, where and how to use those, again, there's IV infusions, there's pills, they have a little bit different side effects. Typically, the tafasitamab and lenalidomide might be a good option for somebody who's not a candidate for like a stem cell transplant or CAR T cells. And the polatuzumab is given with chemo, so that can also be a good option, but you just have to think about the side effects of what it does. So really just looking at the patient, what's your goal for the patient in treating their disease? Do you think, you can get it back into a remission? Do you think you can still cure it? Is it more that you're just trying to keep it under control for as long as possible? And then what are they going to tolerate? You don't want to make them sicker if you're not going to ultimately if you're not going to ultimately cure the lymphoma, you have to make sure that their quality of life doesn't, you want to preserve that the best that you can. And then just what side effects does it cause and what side effects are, acceptable, I guess.
Mm-hmm. So let's talk about this for a minute. Let's bust out a conversation that is a little bit taboo, I want to say, just because I think patients are so afraid to have it. And what I'm hearing in what you're saying, and what I hear in so many conversations with healthcare professionals, is you have all this science to work with. So you have CAR T that you can use, bone marrow transplant. You've got a number of new drugs that are available to you, and we always encourage people to find a specialist, no matter what type of cancer they have. Find a specialist, because there's so much happening so fast that it's just hard to keep up with everything that's happening. So what I hear is that you have a master of the science and what's happened in the science. I also hear you saying that an important differentiator for you and what you might treat a patient with is the patient and or the caregiver experience, right? And I think that is such an important factor that patients and caregivers don't always appreciate, how they have this important information to you, because you may have a choice between a drug that's given this way versus that way, or a schedule that is more restrictive versus less restrictive. But it's really important for patients to talk to you and tell you what they're willing to tolerate, what their work schedule might look like, so that you can think about that, if they want to be aggressive or not. So I would just love, because we say it all the time, right, to patients: you've got to talk to your doctor, you've got to talk to your doctor, you've got to tell them this. I would love for you to just speak to that a little bit, and how you actually want that information, and you use that information not just up front, but throughout the course of treatment, to maybe make adjustments if needed.
Yeah, so I think that this is, such an important conversation for the physician to have with the patient and their family, their care providers, who's ever their support system. So it's very important to establish what your patient's goals are, or what do they want. Now, obviously, everybody wants to be cured. We don't necessarily, we are not able to do that at this time with everybody. So there are patients that relapse, and there's not an option for their treatment, their lymphoma, to be cured. And I think at that point, it's the most important to establish, what does the patient want out of the treatment and what you're doing. So what are their goals? Are their goals to make it, if possible, do they want to live to a certain family event? Do they want to spend as much time with a family member? Do they have a hobby that they love and they want to be able to do that? And knowing what their goals are can help when you have options for treatment. And even things like clinical trials, can they travel for other options? How hard is it for them or their caregiver to get them into the clinic? Because that might affect something, the schedule of, if you have two options and one's given every 3 weeks and one's given every week, that might come into play if the outcomes are different. Now, sometimes you have to say, well, this is how often this works, this is how often this works, but this is, the side effects with this, and this is the side effects with that, and kind of lay out what their life might look like getting that treatment, and then decide how that fits into their goals.
Mhm. Yeah, and I just want to reinforce that it's important that they communicate it upfront, and then throughout the course of treatment, because we've heard you say that there are a lot of options for people, and you're thinking about, are they having neuropathy, right? Are their blood counts low? Are they having other side diarrhea, constipation, other side effects? And so if you don't know about it, and we've had other guests on our shows who said, look, if I don't know about it, I really can't help you, and think about how we can fix it for you.
Right. And I think, if there are options, if you're in a situation where there's an aggressive lymphoma, but it's, curable, but you have to be aggressive and there's going to be lots of side effects, I think it's just important to be honest, because obviously, most likely you and that patient want them cured. And so you just have to be upfront with the patient and their caregiver that this may be very difficult, but, our goal is that we're trying to cure this, and because of that, we're going to accept more toxicities or side effects, or we're going to try for, the short term to have potentially a lot of issues, for that long-term goal. And I think that's also important. I mean, you don't ever want to downplay side effects because they're very, real to the patient, and just making sure that you're, being upfront and this is what happens, and the patient should be asking questions. You should always, ask the doctor, and you always need to tell the doctor if you're having side effects. Some people have something, but they're scared to tell them because they don't want their treatment changed. But it's really important to tell your doctor, because they, if it's something that's going to be permanent and you're going to have to live with it forever, the doctor might be able to make a change that's not going to affect the outcome, but will make that side effect better. So I think it's both, so those lines of communication that go both ways, from the caregiver and patient to the physician, and the physician to the caregiver and patient, is very important.
Yeah, that's right. And the thing a couple of the things I just like to reinforce is people don't have to suffer in silence around physical symptoms or mental symptoms, right? And I just think about the arsenal of tools that you and your team have available to you if they are having side effects, to help them manage through those side effects. And then as well, if they're feeling a little depressed or a little anxious, and we do know that a lot of people, 35% of people with cancer have some level of anxiety or depression, that there are organizations like ours, and I know that you have a team available, on site there to help them manage that. And this is all times when we're just all hands on deck around the patient, and we're here to support whatever that need is, as long as we know about it.
That is so true. I think it's important what you say, the anxiety, depression, that is real. There are ways to help. There are support groups, there are medications, there are just a number of different things. And I think that is something that's very important to address, because even when you get through a cancer treatment, sometimes that's when you see the anxiety and depression, because people have this, they have goals when they're going through treatment, right? They know they have to get so many cycles of chemotherapy. They have a scan at the end, they kind of have a set thing. And then when everything is over, sometimes that's when it really hits them, and they realize what they went through, and there's anxiety about what if it comes back, and what are you going to do? And so that is, there's ways to help. And I think that's also so important to address, because they can make a difference in, treatment and outcomes if you're not treating, the mind and the body.
Yep, the whole patient.
Yes.
And one of your colleagues there at the Ohio State, Barbara Anderson, has done amazing work in understanding this connection between the mind and the body, and how it's so important to, make sure and link those two throughout the cancer journey. And I'm just going to take a second to remind everyone of our telephone helpline number, because we can help with some of these symptoms for sure. And I know people have been asking on the chat, and yes, we are taping this, so this will be available on our Facebook channel and also our YouTube channel. But our helpline number is 888-793-9355. And again, you are free to call that number and say, I don't know what just happened to me, to your point, Dr. Maddocks, that it's, especially if you have an aggressive lymphoma, that you guys may move pretty quickly, get you into treatment, and you're dealing with all the treatment, and then, oh, things look great, come and see me in a few months. And the patient and the family are like, whoa, what just happened? How do I reestablish, myself? And we'll help get you resources, for that. Let's just talk quickly, and I want to make sure that we have time for questions that are coming in. Clinical trials. We wouldn't be having this conversation at all if it weren't for the heroes, both on the medical side and especially on the patient side, who have participated in clinical trials. So when is a clinical trial an option for people, and how would patients and caregivers go about finding a clinical trial?
Yes, though, another great question. So there's always a potential that a clinical trial can be beneficial. So there's different types of trials. So there's different phases of trials. A phase 1 trial is for somebody who maybe they're first testing a drug and trying to learn the doses and toxicities. They have an idea, or there's evidence in the lab that they might be effective in the type of cancer they have. So specifically what we're talking about is lymphoma. And those are usually patients who have that go on those are usually patients who don't necessarily, there's not standard options available to them. So they've had all the standard therapies and they haven't gotten into remission or continue to relapse. We don't have anything that we know is effective or curable or treatable, and so they can do that. There's a phase 2 trial that's gotten through a phase 1 trial. We know the safety, we know in general the toxicity. It has some evidence of activity, and we're now looking at it either and in a bigger population of patients or maybe combining it with other drugs. And then phase 3 trials are, wow, we know this is effective. We want to compare it to the standard of care because we think it might be better than that. So there's always a potential both at initial diagnosis, because we have a standard treatment that we use, but there's trials ongoing looking at adding treatments to that standard therapy to know if it's even better. Now, not everybody maybe is going to qualify, but there's usually, places that are doing those all the time. And then when the lymphoma comes back, specifically aggressive lymphoma, like I said, if there's not an option for something that we know would cure it, then there might be a clinical trial that's combining drugs that are effective or combining something that's approved with something that's not approved. So clinical trials are really always something that should be thought of, both at initial diagnosis and relapse, especially if there's multiple relapses. There is a website that you can go to called clinicaltrials.gov. So clinicaltrials.gov, clinical trials all just together. And that lists all the clinical trials in the United States, and you can search by disease, you can search by specific type of therapy or drug. Also, organizations like yours, I'm sure, can provide patients. If patients call, they can provide options for places that have them. And of course, you should always ask your physician, because most of the time there's clinical trials both at community and academic hospitals that physicians have access to and are aware of. Sometimes a patient might have to travel for a trial, but if they have the means to do that, you can really go, find trials all over the United States.
And we have a question from someone who is asking for us to differentiate what we're talking about here today, relapse refractory, from stage 4 lymphoma. So we should maybe just take a minute and clarify staging and then what we're talking about in refractory.
Yeah. So the important thing about lymphoma is that in blood cancers in general, they have a different staging system than, say, what we call solid tumor cancers, or like breast cancer, lung cancer. So lymphoma staged, it has 4 stages. Stage 1 is when it's in one spot. So one lymph node, or maybe outside a lymph node, but in one spot. Stage 2 lymphoma is when it's in multiple lymph nodes, but they're either all above the diaphragm or all below the diaphragm. So it can be in multiple places, but it all has to be kind of on the same half of the body. Stage 3 is when it's in lymph nodes all over the body, so on both sides of the diaphragm. And then stage 4 is when it's outside of the lymph nodes, either in the lymph nodes and outside, or all outside. And as I mentioned earlier, we didn't talk about staging, but I did say lymphoma, it's a blood cancer. It's something that can go anywhere. So any organ can ultimately have lymphoma in it. So if you have lymph nodes and maybe a lung spot and a liver spot, that would be stage 4. In general, staging is important, and lymphomas have prognostic scores. So we look at a bunch of different things like baseline lab values, baseline patient status, staging, and that all goes into a prognostic model that estimates, the chance of somebody being cured or getting into remission with their therapy. But in general, aggressive lymphomas can be cured at any stage. Again, not everybody is cured, but stage 1, 2, 3, or 4, all are still potentially cured with that initial treatment. Indolent lymphomas are staged the same way, but remember, in general, there's, a small population of stage 1 patients who might be cured with radiation, but in general, those are treatable, not curable. So the stage matters, again, for maybe how long the remission is or other factors about the lymphoma, but it still doesn't, unless it's one spot, change the treatment.
Great. Thank you. And I'm sort of pausing to see if we have any more questions that come in. And I'll just remind our listeners that we at the Cancer Support Committee will go through. So if you want to post comments or questions, we'll go back through those and try to answer those as best we can for you. I also want to remind everyone that our sponsors are Bristol Myers Squibb, Insight, and Morphosis. And we thank you for that sponsorship and for the work you do for patients with lymphoma every single day. And I want to also just make sure that everyone knows where to find you. So Dr. Kami Maddocks, you've been amazing today, really amazing. And you are a professor of clinical internal medicine, and you are the director of the lymphoma program at The Ohio State University James Comprehensive Cancer Center. That's a bit of a mouthful, but we'll remember the Ohio State University. And I see behind you that there's the O and the Buckeye. So of course, I wouldn't be a good Hoosier if I didn't say go IU and that rivalry. So if anyone wants to get in touch with you, they can find you there at the Ohio State James Comprehensive Cancer Center. And we could certainly put people in touch with you as well. And I just want to thank you for spending time with us today and want to give you the last word. Is there anything that we didn't cover today that you want to make sure that people are aware of as they think about their journey or their loved one's journey with refractory or relapsed lymphoma?
I think the most important thing is it's dealing with cancer diagnosis is a difficult time. It's important to reach out and use your support systems, use the different organizations, and make sure you communicate with your physician, as mentioned. Ask about things like clinical trials, and recognize that we still have a long way to go and research is important so we can cure more people, but it is, we have more options than ever before. And, as we look towards the future, I foresee that we'll have, more options. So it's, always good to be hopeful about what's going on and, make sure you reach out if there's any questions or concerns when you're being treated in something. It's always okay to have a second opinion, even if you want. Ultimately, most doctors will work with, or doctors will work with your doctor. So just because you get a second opinion, or maybe see if there's a trial available, or see if somebody would use the same treatment, you can always get that. Doctors work very well together. You can get that locally and it doesn't hurt anybody's feelings. Everybody just wants to do what's best for you.
Thank you. And again, options, options, options. And I think that's really the good news story now. And thank you again for being here with us. And with that, we're going to close this particular session. And thanks to those of you who have been with us for almost the last hour. We appreciate you being a supporter of the Cancer Support Community, and we appreciate your interest here. Please share this information widely if you know of anyone who would benefit from it, as well as all of the resources that are in the comment field. And a final reminder, our telephone helpline is 888-793-9355. Thank you so much. And with that, we'll wish you well.